First of all, thank you so much for having me. My name's Jenna. I'm a practitioner working in Dubai. So far, since I arrived, and admittedly I did arrive a little bit late because I only flew in this morning. Oh, thank you very much. Thank you. How do I get going? There we go. We've all been talking about technology so far. I am going to take a little bit of a turning point from technology. But one thing I will note is it's been really nice to listen to technology based on real data. And you're talking about pharmaceutical industry, you're talking about interventions that you're making within the hospitals. I come from a region where there's an awful lot of technology, and it's all surrounded about social media. And it's about how we market healthcare and how we market medicine. And I actually think that's quite sad. And these days in the UAE, an awful lot of how good you are as a practitioner and how you're perceived is actually how you sell yourself. And I think it'd be really important if we don't forget that healthcare has now become a bit trendy. AI is also trendy. The area of medicine that I work in is a huge, big buzzword at the moment, and I don't know whether it is here, but it certainly is in America. It's emerging in the UK, it's emerging around Europe, and it's absolutely gone wild in the UAE, and that is about longevity. So I'm getting a few nods, yeah. So it's not just about how long we live, it's about how we live. So I'm now 40 years of age. I would like to continue living my next 40 years in the same way as I lived my last, potentially a little bit more sensibly than I lived the first 40 years, however. So a little bit about me. I am really lucky that longevity medicine came into fruition because I've always had three areas that I've loved. Health, general health, well-being, this sort of buzzword as well of wellness, and it's about how we integrate our social health, our physical health, our emotional health. How do we bring them all together? I've also been a huge big advocate for fitness and about how movement integrates into our emotional health, our mental health, you get the idea, and our physical health. And then on the side, when I finished university, I did quite a lot of courses, diplomas in cosmetics. It didn't fit with anything else that I was doing, but I thought at the time, I know, I'll be a little bit creative and I'll get to do a few little injections. Who doesn't like doing injections? And none of it went together, and everyone said, Jenna, you've got to focus on one thing. You can't just do your PT training. You can't just be sort of a wellness advocate. You can't just look at mental health, emotional health, and then stick some needles in people's faces. And then longevity medicine came in, and actually it wrapped its arms around all of those things. So what is longevity medicine? Anyone want to answer? What's it about? Oh, come on. I know you're all tired, but come on. Go on, you're laughing there. Just stab a guess. So when we're talking about longevity, it's not just about trying to live well. It's actually about cellular medicine. We're talking about cellular medicine. So it's actually looking at what declines as we get a little bit older. So we know, for instance, that certain hormones decline. We've always known that, but we've not always potentially replaced them how we should. We know that coenzymes like NAD+ decline, but we haven't really understood why or the importance of them. I say that a lot of what I do comes under supplements, peptides, if you know them, hormones, and then snazzy stuff. The snazzy stuff are things like hyperbaric oxygen, plasmapheresis, etc. So we use lots of different things within longevity medicine to try and keep people feeling better for longer. So we've got, like I say, supplementation, the snazzy stuff being things like stem cells. There's a lot of testing, actually. Now, today, one of the panels I thought was really impressive because they talked about how the data is important, but it's not the data that's important, it's how we extract that data and what we do with it. One of the downfalls at the moment in the field that I'm in is testing for the point of testing. And actually, you've got quite a lot of vulnerable people that are desperate to live longer. Perhaps they've had a death in the family. Perhaps they've got some poor genes. They've done the genetic makeup and they're scared about what they see. And actually, those vulnerable people are particularly vulnerable to being told you need to do X, Y, and Z testing. And actually, you can excise quite a lot of money from these people with absolutely no change to their outcome. If somebody is genuinely really interested to know something, of course I will run that test. If that brings them peace of mind, I will run those tests. But personally, I think as practitioners, bearing in mind I work in a private healthcare system, I feel I've got a duty of care to tell people when a test is not going to change the outcomes. So data is important, but we also need to make sure that we pick it appropriately for our clients, and we tell them if it's going to be useful and whether it'll change the outcome for them. We've also got proteomics. That's one of the tests we run. We send to America, called a soma scan. You can actually look at the proteins that you find in the body to give you a risk score, which is, I have got to say, exceptionally accurate so far, looking at your 20-year risk of different types of dementia, and it will also give you your 6-year cardiovascular score. It can even tell you whether you're smoking and your basal metabolic rate, and having run those tests side by side with DEXA scans, it's amazing how accurate they are. And I'll be honest, some of the technology is perhaps a little bit over my head, but I use them, and I interpret them with patients. This would come under all the snazzy stuff. So the DEXA scan I've just mentioned, it's not just about finding out people's weight. We all know that. We all known for ages that BMI is not particularly the most useful data piece, but it's about finding out what's their body fat percentage, what's their bone density, etc. Huge important piece for women sort of post-menopause. Who knows Brian Johnson? Yeah, okay. So Brian Johnson he kind of leads the world of longevity. He's not a physician. He's a gentleman that's very wealthy, and he decided to basically use himself as a case study for how he could live longer. He has a company called Don't Die. One of the things he did was he identified that plasma from a donor would likely be healthier, freer of toxins, freer of heavy metals, free from autoimmune type antibodies. And he gave his plasma to his elderly dad, and he took his son's plasma and put it in his own body. Strange gentleman. There's a lot of talk about him online, but what I will say is I encourage the fact that he's trying to actually give data to us, and we're all learning from him in the process. Hyperbaric oxygen is an absolutely wonderful tool that we have access to. I struggle to find the downside other than the resource of time and finance that goes behind hyperbaric oxygen. Fantastic for healing if it's done properly, and by properly I mean is the atmospheric pressure at the correct amount. You can get small little soft hyperbaric oxygen chambers you can take at home, but the amount of benefit you're going to get from it is not quite the same as doing it in a medical facility with a qualified medical practitioner that's watching it, and the amount of time that's needed is quite significant. For most hyperbaric oxygen places, you're looking at 2 hours a day for 2 months at a time. So a significant piece of time. It can open up new memories. It can help the brain to rewind new tissues, helps with traumatic brain injuries. Also, huge amount of data to show that it helps people suffering with autism spectrum disorder. It is a fantastic piece of kit, but not cheap. And then just a few other bits, such as VO2 max, fantastic marker for longevity, such as grip strength. These two are not necessarily considered a direct correlation with living longer, but more a byproduct of the way that you're living will increase your VO2 max, will increase your grip strength, and therefore you sort of have a reduced all-cause mortality. Now, one of the major pieces in longevity at the moment are peptides. Has it got the same kind of... In the UAE, in the UK at the moment, they're all going mad for peptides. Everyone's talking about them. They don't always know what they're about. What's the status here? People using them in clinical practice? So peptides are short chains of amino acids. There's an awful lot of people that are buying them online at the moment. What they do is they send little messages to the body. Insulin is a peptide. Mounjaro, Ozempic, or GLP-1 agonists are peptides. HCG, used in fertility, is a peptide. Notably, they're usually injected, because if we take them orally, our proteases will break them down and they become amino acids and they cease to send messages. I use them day in, day out with clients. A lot of British practitioners won't. The reason is they don't have their full FDA approval as yet. There are gallons of studies on certain peptides in the human cohorts, but there are not gallons of studies for a lot of the ones that we're using on the human cohorts. It's going to take an awful long time to work their way through them. There is a lot of anecdotal data. If we think about the chemistry, we know that they should be safe. They don't accumulate in the body. They break down to amino acids. Where rarely they do have a bit of a histamine release, so we know that allergy could be a bit of a problem. And they are currently in our foods, and they are things that we have in our body at the moment. But we know that certain processes decline as we get older. So what do peptides do? Anything. There's a lot of peptides now being used in chemotherapy and as an adjunct to improve our immune system. It actually changes the way that our CD4 cells will actually work and be able to identify bacteria, viruses and fungi that it's meant to attack. There are lots and lots of athletes that are now using things like BPC 157, less so CJC, ipamorelin, but thymosin beta, GHKCU. These are all things that decline as we get older, and they help reduce inflammation. They help produce new tissues. They help with angiogenesis, that we get more blood supply to certain areas. I know a few of you are nodding, so I know there's a few of you that are using them regularly, but I'm still just telling you that there's a whole world out there. And I do think that mimicking our natural processes like this is probably the future of how we're going to use healthcare. And it's a huge growing industry. The only problem is there are a lot of people that are ordering peptides online. Any side effects I've had with people that are using peptides are from those that have used them online, because we don't know what they're getting. Why anyone would think it's okay to inject something into their bodies that they don't know anything about is beyond me, but that's us humans. We're a bit soft at times. Like I say, there are various chains of amino acids. Some can be taken intranasally. If they're taken intranasally, it depends on the size of the peptide as to whether they can cross the mucosal barrier. Most of them can't be taken orally, but BPC 157 can be. There is some evidence to show that it still reaches the rest of the body, but to be honest, it's very good for gut issues as well. Different types of peptides, I break it down into different categories, and I say to people, like, what is it you want to achieve? You can't take them all. We're looking at something sustainable. And again, going back to that duty of care as physicians, especially in a private healthcare system, to say, I don't want you to spend out unnecessarily, and I want you to do something that is going to be able to work forever. So there's something that you're doing now you can do in 2-3 years down the line. You've got longevity type peptides, some that actually reduce biological age. They are shown to elongate the length of your telomeres, which is quite exciting. Immune support, that's your thymosin alpha. Mitochondrial support would be something like MOTS-C. It actually helps the way you metabolize your sugars and how you metabolize cholesterol, etc. And it actually it makes the body work more efficiently from a metabolic perspective. Recovery, they're your thymosin betas, your BPC 157. They are the peptides you have to be careful of. If you are allowing to induce new tissues, if you are allowing an increased blood supply, if somebody has an oncology type process going on, you have to be very, very careful, because you can propagate the growth of that cancer. So it's always advisable that they have done their oncology screening, you've taken a full history, you've done some basic blood works before you use them. Performance type peptides are usually ones that help to increase growth hormone. Now, if we just give people human growth hormone, it's going to increase their risk of diabetes, it's going to increase their risk of joint effusions. But if you tell the body, make a little bit, just a touch more growth hormone, maybe the amount that you had when you were in your 20s or your early 30s, that's physiologically more appropriate, and people tolerate it very well. It changes their body composition, it changes their performance in the gym, and generally they feel that they've got a lot more energy and they recover that little bit better. I tend to link it with a peptide called AOD 9604, which is the Barbie peptide. Women tend to love it. You can guess why. It helps them to reduce a little bit of weight in a physiologically natural process. And then you've got other peptides, some that help with libido. There are some that help with sleep. There are some called nootropics that help increase brain-derived nootropic factor. Really good, again, for people that have suffered any kind of brain injury or trauma. GLP-1 agonists are a huge, big piece, which I'm just going to touch on because I know I don't have too long. Has anyone tried a GLP-1 agonist? Put your hand up. I have. I tried it. I made myself really ill. Anybody else? In the UAE, the use has gone rife, and it's not just the UAE. I've got lots of patients all over the world. I don't know how they found me, but I speak to people regularly all over. People from America, Canada, the UK, Europe, Australia, and they're getting their hands on GLP-1 agonists, and they've got, I don't know, an inappropriate reputation. So these are medications that are helping people to lose weight, but they're only really FDA approved, majority of the time, for diabetes. However, they are changing lives when used appropriately. The inappropriate use of them is what is causing muscle wastage, is causing people to eat up their own muscles, is causing Ozempic face, where people are losing a lot of fat from their faces. It's causing arrhythmias in some of the young girls that are managing to abuse them. And I think, again, we have to be very, very careful. One, not to forget the benefit of the GLP-1 agonist for the right patient. I've got so many patients that it has changed their life, completely changed their life. If somebody is morbidly obese and they are struggling with their activities of daily living, and you can help strip a little bit of that weight with ease, get rid of the food noise, remembering in the work that I do, I often encourage people to do their genetic makeup. And there are a lot of people that have got mutations on 4 particular genes that regulate appetite. If people have mutations on their genes, they are physiologically going to struggle to know when they're full. These people are more predisposed to binge eating, especially if they also have, in conjunction with that, if they have low abilities to make serotonin or they're breaking it down very quickly, they're going to inherently want to eat more because they can't control their appetite and they want to lift their mood. We know that eating increases dopamine and serotonin. You can literally change that person, bring down their cholesterol, bring down their hypertension, give them a life back, increase their confidence. I'm not opposed to using it like that. However, we have got to be very, very careful that we don't abuse it. Everybody knows about hormone. So this is a bit of a whistle-stop tour, but I know I'm on a bit of a budget of time. One of the other major pieces we've talked about, well, we haven't really talked about supplementation, but I will just give a nod to the use of supplements. A lot of people don't like using supplements because they feel like, they don't really do anything, I don't feel anything. They're ingredients for life. As we get older, especially depending on where you live, you might not get enough of the things that you need from food in order to thrive, not survive, but thrive. Adding in vitamin D. Anybody met a patient that's got naturally normal or optimal levels of vitamin D? I think I've met one and I have no idea why. And I get a lot of patients that come in, they're like, I spend all the time in the sun. The vitamin D is still not where it should be. Supplementing that is absolutely wonderful. I can always see on somebody's blood panel whether they're using supplements or not. We've talked about peptides, the benefits and the curses. The next piece is hormones. We know that our hormone levels tend to decline from the age of 30. Men's testosterone starts to dip down quite dramatically from the age of 30. Women at 35, our estrogen starts to take a nosedive. That's why nowadays we're talking more about perimenopause starting around the late 30s. Now, historically, we would wait for symptoms to come in, and I find that quite sad because there's also the physiology that goes behind what's occurring with lower hormones. If we have hormones that are declining, we don't operate in the same way. And likewise, when we're not operating in the same way as we should, our hormones tend to decline faster. If we're not lifting weights, if we're not moving appropriately, our testosterone will go down. Hormones have a huge impact on everything. I used to work in the ICU department. Someone else mentioned ICU here today, so I don't know if they did too. And the women that suffered with postnatal depression were the ones that were the most likely to try and commit suicide in the most graphic ways. Graphic, that's all hormone derived. And yet we brush off the fact that hormones play such a huge part of our life and how we feel. And it's still got a little bit of, we still don't always support men and women when we're talking about whether it's testosterone replacement therapies or for women like full-blown HRT. And I think that's sad. We also know, and if we look at men, testosterone levels have gradually declined for many, many decades. So even now what is considered within the references of normal is actually would have been abnormal 100 years ago. And yet we expect them to just carry on because testosterone replacement therapy has got a bad rep. The guys that potentially abuse it in the gym are putting themselves at significant risk. You give somebody lots and lots of testosterone, their blood gets sticky, their heart gets bigger, especially if they're coherently also using human growth hormone. You're creating a perfect storm for a nice little clot to put up camp and cause a heart attack. There's lots of other things. If somebody's got a bicep tendon tear, the first thing I say is how much testosterone are you on? Because their tendons and their ligaments can't keep up with the mass of their musculature. But that doesn't mean that when appropriately dosed, that testosterone doesn't make a man feel more alive, feel like they've got more mojo, feel more confident, increase or remove their brain fog and increase their mental clarity. And actually the same goes for women. Testosterone has an important role for women too. So this is, I'm not going to go through the study, but it's basically just showing that our hormone levels decline and that we should potentially be doing something about it. We do talk about the risks of HRT. And let's not ignore that. There is a risk with everything. Whenever I see patients, it's an ongoing balancing act of what do they want to achieve, what are the risks at their life at that current time, and what are the outcomes, and making a decision as to where we pitch it so that we get that scale just about right. There are risks associated. If you increase somebody's estrogen inappropriately for too long, especially if it's oral estrogens and E1 and E3, there is an increased risk that you're going to get breast cancer or ovarian type cancers. However, we have to weigh up with the cardiovascular benefits of keeping our estrogen high. If our estrogen is higher, we know that we tend to manage our cholesterol better. We're less likely to deposit fats on our abdomens. And also, let's think about it from an aesthetic perspective. Our collagen decreases by about 25 to 30% within the first 5 years of perimenopause. We all want to hold on to our hair, our skin, and also collagen is just so important for every single aspect of our body. It's the most important protein that we have. So although we're saying that there are risks, we should always be aware of the risks. We should always speak to our patients about those risks. I don't know how you guys feel as physicians and practitioners in the healthcare industry. I no longer feel like it's my duty to tell patients what to do, but to advise them, encourage them, and work with them and give them the choice at the end of it. There are two different types of HRT. This is both for men and women. You've got hormone replacement therapy. Then you've got bioidentical hormone replacement therapy. In many countries, they are still against bioidentical hormones, and I understand why. It's exceptionally practitioner-led, which means that the dosing and the regimes that are given depend on the compounding pharmacy and the individual practitioner. So it does put a lot more risk out there. However, it also encourages precision medicine. If I was to take two different tables of women and give them all the same type of HRT, they would all respond a little bit differently. What I love about bioidentical hormones is the fact that I get to make it bespoke and make it for you at the right dose. And rather than having big jump ups between your levels of estrogen, progesterone and testosterone, I can do it on a very, very, very micro sliding scale. You're less likely to experience the challenges of having huge big jumps in hormones, but it also means that it's more tailored to you, less side effects, etc. Would you consider HRT? That's up to you. So I think I did quite well to keep it quick. I am British and I'm from the north, so we tend to speak quite quickly anyway. Do you have any questions, or are you desperate to run for lunch?
First, Jenna, thank you for a very nice session. It's a very interesting topic. My question is, where this lifestyle changes, like sleep, no stress, plant-based diet, where does it all fit in with all that you said?
It's the fundamental. Everything I've just mentioned is the cherry on the cake. So my favourite client, I had a patient yesterday, he was an MMA fighter, and I said, you're my favourite kind of client. He's nailed his nutrition, he's nailed his sleep, he's nailed movement, he's got very low stress, he's actually just retired, so his finances are in order. Now I get to do my work, because unless people put in the groundwork, and thank you for the comment because it's so true, unless people have put in the groundwork, none of what I'm suggesting is going to work. It just won't. If somebody's mental health isn't in check, it doesn't matter what we do, they're going to feel tired, they're going to feel sluggish, and they're not going to be physically optimized. It's just the way that it goes, sadly. So there's a lot of work that the patient must do before we even look at this. And I think a lot of people come in and they think they want to improve their performance at the gym. They want to sleep that little bit better, but they're not prepared to do the movement and they're not prepared to have the sleep hygiene habits. It's not going to work. What these do is a little tiny message, especially the peptides, the hormones, the little messages that just push the body in the right direction. So if you make the right intervention, you will get a much bigger response back. But without the intervention, you ain't going to get anything. So yeah, thank you. Good question. I don't touch anybody below the age of 30. I think one, from an ethical perspective, because I've mentioned some of the things that we're using, they're non-FDA approved, and I want to make sure that once somebody is old enough that they can take on board those risks and they can process them and then decide. Anecdotally, by the way, patients feel amazing, and it's exceptionally rewarding area of medicine to be in as a physician. I mean, I really love it. Also, there's no need below the age of 30 because nothing, if we look at NAD+, NAD+ is a coenzyme that helps to create ATP, and it's really important part of DNA synthesis. We know it doesn't start to decline until the age of 30. We know our hormones, and the vast majority of people don't start to decline to the age of 30. So I think once people start to get around 35, 36, that's kind of like the right sort of age. And obviously there will be some level of symptoms, but you also want to look, we talked about data, look at their data, look at how they're feeling, take a collaborative approach, and then make a decision. I have a hard rule of nobody under the age of 30. That's just my rule, but people in the industry tend to speak the same language on that. Yeah. Again, that's a really good question. It depends so much on the individual. And when I said that longevity in medicine, or the future of medicine is going in this direction, what we're talking about is cellular medicine, but precision medicine for that individual. So if somebody I don't think is mentally capable, or there's other mental health issues that are going on that is driving this desire for weight loss, then of course I wouldn't be able to prescribe for them. I'd have to recommend that they went to see somebody like yourself. I have a few ladies that have got very, very low body weight, and they come to me and they're asking about retatrutide, which is the new GLP-1 agonist, triple acting that everybody's talking about. For me, it doesn't matter if they want to pay a consultation fee, they want to come back, they're not the right client for it. So you have to take it on an individual basis. I would spend time talking to them, find out where their desires are coming from, and then as part of any sort of health consultation, I always do a 360. So part of that will be about stress, mental health, etc. What are they, how are they feeling? So you have to know that they are mentally stable enough to be able to start on that journey as well. But it's not just with GLP-1 agonists, it's with everything actually. So if somebody's looking to improve their metabolic functioning, there are a few different things that I would consider. But bearing in mind, as a sort of a note, you have to recognise their family history. Do they have a strong oncology family history? Have they ever had cancer in the past? Have they got any chronic inflammation? If they're over 50, would you try and encourage them to either do an overseas cancer test or a true check, which actually looks, it's not perfect, no test is perfect, and cancer doesn't wait to be tested, but it will screen you to see whether you have any tumour DNA that's circulating in the body at the time. That would be my main protocol. If all those boxes were ticked, then I would say, okay, well, let's look at things like MOTS-C, fantastic for helping, again, mitochondrial function and metabolic efficiency. NAD+ would be one of those. And then you've got some supplements like coenzyme Q10 or L-carnitine as well that's going to help with their metabolism. Again, it's not going to take away from the fact that they have to eat well, prioritise their protein. Amino acids are pretty much everything. If we want more collagen, it's not about just sticking peptide GHKCU in. It's about eating plenty of amino acids so you can process them into collagen. Likewise, they have to do the groundwork too, but these things are just going to help nudge them in the right direction. That's all this is. It's a series of nudges in the right direction to support them. So thank you. Thank you so much.